Thank you for inviting me, Comac, and I will proceed. My topic is going to be less entertaining than what you just heard, but a little different. I first want to define what we mean by primary spinal syringomyelia. And it's syringomyelia that originates from an abnormality which is entirely at the spinal level, distinct from syringomyelia that is related to cerebellar tonsillar descent or ectopia, aka Chiari malformation. And I want to talk briefly about the pathophysiology of primary spinal syringomyelia. You've heard quite a bit about the pathophysiology of Chiari malformation. So, as you have heard in connection with hindbrain descent, CSF pulsates synchronously with the pulse and respiration. And when the CSF pulse hits a partial obstruction, it becomes easier for the spinal fluid to enter into the spinal cord rather than to travel as it normally does along the outer surface or peel surface of the cord. And if the cord tissue is broken down for some reason, such as from a spinal cord injury, it becomes even easier for the spinal fluid that pulsates to enter into the spinal cord itself and cause a fluid-filled cavity. Now, partial obstruction of the subarachnoid space, which is the underlying pathophysiology of primary spinal syringomyelia, can result from a variety of factors. A spinal cord injury or surgical trauma can do it. Post-inflammatory scar can result from infection, from blood into the subarachnoid space, such as can occur from an injury or particularly from a subarachnoid hemorrhage, such as a ruptured aneurysm, or from some foreign materials that were injected into the spinal canal. It used to be that we had a rather toxic inflammatory generating material used for myelography called the pantopake, which is no longer used, but that did produce in some people an inflammatory reaction. Bone fragments from an injury or from a spine deformity can do it. Rarely, even a disc protrusion can do it. Occasionally, an arachnoid membrane, as I will show you, can form a partial obstruction of the spinal fluid circulation, and we call that an arachnoid cyst. And sometimes tumors can produce this, either tumors that are within the dura but outside of the cord, or tumors that are even outside of the dura, as long as they produce obstruction of the subarachnoid space. So, in a sense, syringomyelia is a symptom of subarachnoid stenosis. And we are, of course, familiar with the narrowing of the subarachnoid space in Chiari cases, and below a traumatic scar, it can result also in syringomyelia. And with that said, the treatment of post-traumatic syringomyelia in the first instance must be directed at eliminating this partial CSF obstruction at the spinal level. What do we use for diagnosis? Well, MRI with or without gadolinium is by far the most commonly used and very appropriate way of diagnosing primary spinal syringomyelia. But occasionally we resort to myelography followed by a CT scan so that we can observe delayed flow of contrast, and with a complete subarachnoid block we can even bracket the obstruction from both above and below, which may be very important in terms of how we proceed to treat this particular individual. And in that sense, myelography may define the surgical strategy. what are the situations in which myelography, using gadolinium, by the way, is or may be helpful? A syrinx cavity without an identifiable scar or obstruction, a diffuse honeycombed syrinx, sometimes in the identification of an arachnoid cyst or membrane, and particularly to bracket the upper and lower limits of a focal scar, because the extent of that subarachnoid scar may determine how we treat this particular patient. What are the limitations of MR scanning? Well, unlike CSF flow studies that we're used to seeing at the cranioscervical junction, there are no reliable spinal canal flow studies to date. There is an enhanced T2 MR scan, which some people have used, but it is not as useful in my practice as myelography. Focal obstructions can be missed if they're out of the imaging plane, and it is difficult to define the rostrocaudal extent of a focal obstruction of the subarachnoid space. Again, to bracket an abnormality, we sometimes do myelography both with a puncture introducing contrast up here and from below, and joining those two, we can see the area of obstruction. I want to talk first about syringomyelia as a complication of spine injury or post-traumatic spinal cord cavitation. And here is a illustration from one of Dr. Millerat's papers, which actually shows the well, maybe it does, maybe it doesn't. Okay.
It's this top one here. Just push the top one.
Oh, this one?
Yep.
Okay. Shows the rupture of the cord due to spinal cord injury. And this is a particularly difficult problem to treat because you're really treating the entire subarachnoid space. There are some typical things about post-traumatic spinal cord cavitation which are not always recognized, because the spinal trauma may have been very trivial, and this could be surgical trauma from somebody who had a tumor removed, or injury that was complicated by infection, such as an open injury from a stab wound. It is not uncommon for years to pass between the injury to the cord and the development of syringomyelia. And it is also not uncommon to see the first manifestation of spinal syringomyelia with somebody who coughs and sneezes and suddenly develops loss of sensation in an extremity. And this is from an old paper, symptoms that are most common with post-traumatic syringomyelia: pain on coughing, spontaneous pain, awareness of sensory deficit, excessive sweating above the injury. And I want to just add something to that. The reason that people with this sort of injury may have excessive sweating above the injury is actually that they lose the ability to perspire below the injury. So for the body to maintain temperature regulation, the perspiration becomes limited to the area where innervation is intact and the person can perspire. That said, it is also true that patients with a significant spinal cord injury or syringomyelia of the spine may lose the ability to regulate their blood pressure normally when they're in the upright position, and this can lead, as a question was asked yesterday, to syncope. and some people may remain asymptomatic. Now, we've recognized that with our increasing ability to diagnose this, the reported incidence of post-traumatic syringomyelia following spinal injury has increased. We used to think it was 2 or 3%. We now recognize with MR scanning that it is far more common. But one of the interesting questions that perplexes people is, why doesn't every patient with a spinal cord injury develop syringomyelia? And in fact, the same consideration applies to patients with hindbrain descent or cerebellar ectopia. Why doesn't every patient who has tonsillar descent develop syringomyelia? Well, one of the possibilities that was suggested by Dr. Milrat is persistence of the central canal. We all have a central canal, which is a fine channel within the center of the spinal cord. And in most people, it is always present at birth. And in most people, it disappears as we get older. This is a study out of Japan which showed that, yes, the central canal is open and becomes progressively occluded with age, but even in the 10th decade of life, there are some people who have a persistent central canal of the cord. Well, what does this thing look like? It looks like this. And I'll show you other examples in a moment. It is typically sort of like spindle-shaped, and if you look carefully, it has a little extension, even up there, sometimes down there. And about 30 years ago, when I looked at this and saw it for the first time, I thought, oh, I know what to do for this. I got to do a posterior fossa decompression for this to make it go away, because this patient has pain. Well, it doesn't work. It also doesn't work. It generally doesn't go away. I thought another patient had a disc protrusion just above it, and I took that out, and the residual central canal stayed unchanged. Here's another one, which is very similar to one that you saw Dr. Mayer show. These things are spindle-shaped. They do not widen the cord diameter, and they are not surgical problems, in my opinion. Typically, they're like a bullseye in the center of the spinal cord. They're round, and they, in my opinion, are not responsible for clinical symptoms. So when I see a patient who has this kind of finding, I look for other causes of their symptoms. I also think that radiologists are the main problem with this diagnosis, calling it syringomyelia or syringohydromyelia or hydrosyringomyelia. They want to cover their territory, but really I think the community at large would be served if we distinguished between a residual central canal and call that hydromyelia, as some people do, whereas syringomyelia is a pathological entity. So we're going to talk about congenital arachnoid cysts in a moment. And here is a patient who has a syrinx. You can see it right there. And I could not make out any area of abnormality that would lend itself to surgical treatment, and asked our radiologist to perform a contrast injection. Here is the contrast being injected up there, and you can see right there a meniscus. And when we went in, we found at this level a membrane, and you can see how this is within the dura. The dura is being retracted to each side. This is an arachnoid membrane, which we then severed and restored the normal circulation. And this is the same patient after the arachnoid membrane causing the cyst had been removed. Here's another patient. Again, you see the syrinx cavity right here at the lower end. And again, there was no obvious explanation for this. This patient had been treated elsewhere with some ineffective approach. And we traced this down and found a rather suspicious abrupt termination of the syrinx cavity. And when we opened this patient up, we found something that I've never seen before or since, but we had actually a diverticulum of the arachnoid forming, going through the outer layer of the arachnoid, forming a little arachnoid cyst within it, obstructing the flow of spinal fluid. And this is what it looked like when we injected some contrast so that we could see the outline of this cavity. And when we excised this, the syrinx went away almost completely. Some little area that you can see is still present, but tiny. And this patient remains free of syrinx to date. I just saw him a few months ago. Post-traumatic syringomyelia may occur with or without bone deformity. And in assessing these people, it is very important to establish whether the subarachnoid stenosis is complete or incomplete, whether it is extends over a wide area, in other words, many vertebral segments, or is limited to just one area of one vertebral segment, for example. And also, it is important to establish whether you're dealing with something that's very high in the cervical region, because in a direct approach to the high cervical spinal cord in somebody may risk interference with the respiratory drive, so we're very careful to manage these people with minimal invasiveness. I've already talked about this in a way, but let me just say that sometimes there are patients where we cannot define a subarachnoid scar even with myelography, and particularly, as you'll see in a moment, if the subarachnoid stenosis extends over a wide area, we have no alternative, at this time at least, except to shunt these people. But when we do, shunting into the subarachnoid space is best assuming that there is no pathological process that prevents resorption of spinal fluid from the subarachnoid space. And some people whose syrinx develops after meningitis or after subarachnoid hemorrhage do not resorb fluid well from the subarachnoid space, and we have to shunt them either into the chest or into the peritoneal cavity. Here's another case of focal arachnoid scarring, which is not evident on the MR scan. The cavity is slightly eccentric, and here we bracketed the obstruction from above and below because it was not very clear. And when we went in, we found a blockage due to an arachnoid membrane, again outlined here with indigo carmine, which I like to use so that I know exactly what to cut out and where. And here it is after surgery. The syrinx has collapsed. This is another one. I think you can see this dark outline of the syrinx cavity. Here's the block, very obvious on myelography, myelo-CT right there. And there I aspirated before resecting, and we sew in a dural graft, and here is the small residual in the early postoperative period. I mentioned before that bone can produce extradural compression in a post-traumatic situation, and this may require removal of bone, sometimes from the front, sometimes from the back, sometimes both. And this is an illustration of how an injury of the cervical spine, for example, can produce complete obstruction of the subarachnoid space. And after an anterior procedure, removing this bone element, the syrinx gets smaller. Here is an actual case of this sort. And you can see the area of injury right there. And the syrinx, which is irregular but extends way up high in the cord. Syrinx is smaller. I mean, I can go back and show you again just for comparison, but it is clearly smaller, has not disappeared completely after an anterior interbody fusion. Here's another case of a woman who fell down a set of stairs I treated some years ago. And here you can see the syrinx cavity. And she came to me months after her injury. And it is interesting to see that although her injury was in the lumbar region, I don't know whether you can see this, but her syrinx cavity extended into the thoracic region, and in fact, it extended all the way up into the cervical cord. We treated her with a two-stage procedure, an anterior vertebrectomy, and you can still see some of the syrinx cavity and still see some of the deformity here. And then we went and put in a dural graft over here, and her syrinx hasn't disappeared completely, but it is certainly no longer up in the cervical region. Syringomyelia, as I said, can also result from surgical trauma. This is a patient who had had a tumor removed, spinal tumor removed, and she has a syrinx cavity right here. And when we looked at this surgically, there is scar in the subarachnoid space at the site of her tumor removal, and we excised that scar. That said, I would also tell you that in my experience, people's propensity to develop scar in the subarachnoid space, as also in other cavities, such as the peritoneal cavity, differs widely. It's probably genetically determined how much scar we develop. And diffuse scarring of the subarachnoid space, as I mentioned before, may not lend itself to resecting a scar. You cannot resect a scar over many vertebral levels, and you are more likely also to cause cord injury doing that. Here is a patient with an example of a subarachnoid scar that extends way, way up over several levels following a subarachnoid hemorrhage. I mentioned before that high cervical scarring poses a particular risk of respiratory problems if approached directly. Here is such a case following in a patient who had had a spinal injury and has a syrinx cavity extending way up high here. And using here's another example, by the way, similar situation, very high cervical syrinx with some adhesions. And this approach was first described by some Indian colleagues and some Greek colleagues. But if you reduce the pressure of spinal fluid up above this partial obstruction, you can diminish the size of the cavity. In other words, to use a term that Bernard Williams coined, you reduce the filling pressure of the syrinx cavity. And this is called a thecoperitoneal shunt, which we have used to reduce the syrinx effectively in patients with high cervical lesions. And they're most useful in high cervical lesions where we don't want to manipulate the cord to put a shunt into the syrinx cavity, as we sometimes have to do as a last resort. This is an example of somebody who had developed a syrinx cavity following resection of a spinal cord tumor. And I thought that going back in here where she had her tumor removed would likely result in neural deficit, which she really did not have. And so I placed a shunt just rostral to this obstruction area into the spinal subarachnoid space, and her syrinx cavity got considerably smaller, and she was better off. Shunting of a syrinx cavity, which used to be our mainstay of treatment, is still performed rarely with a multi-perforated shunt, such as you see here, that we put into, where we put the end with multiple openings into the syrinx cavity and thread it in, and then leave the far end either in the subarachnoid space, or we hook it up to a tube that goes into the chest or into the peritoneal cavity. And this is just a cartoon to show you how that works. And here is a patient who was treated in such a manner because, as you can see, it's very, very difficult to define just where the scar here is, and it did not lend itself to resection of the scar over many levels. There would be at least 3 or 4 levels of subarachnoid scar, that, as I see it here. And again, the syrinx considerably smaller. After shunt, you can just see the shunt tube come out there. Here is the same patient I showed before, following subarachnoid hemorrhage. In that kind of situation, we have no alternative but to shunt, at least at this time. But shunts are not without complications. And in our own experience, obstruction of the shunt was the most common complication that we saw. And it led actually to my designing a shunt tube that has less risk of obstructing. But as Dr. George said in another connection earlier today, the shunt tip, although patented, doesn't find any interest in industry because this is not a big money maker. But the shunt can get stuck to the dura, which we call tethering, different from tethering that we heard about yesterday. It can become infected. It can, in situations, if you recall the slides that I showed from Dr. Millerant's paper, if there's a direct communication between the syrinx and the entire rest of the subarachnoid space, if you shunt such a person, you will develop a low spinal fluid pressure condition, which is associated with its own set of symptoms. And there are other less common complications. So we shunt only when there is no alternative. And certainly in my own practice, shunting has become far less frequent over the years over which I've treated syringomyelia. This is just an example to show you how the shunt can become obstructed, because if it works well, the syrinx cavity will collapse against the openings, and it's the body's reaction to allow tissue to grow into these openings, so the better it works. If the syrinx collapses, then the shunt will become occluded. But if the underlying mechanism has not been dealt with, fluid will reaccumulate and require replacement of the shunt. Sometimes the shunt is not placed adequately. Here's a person who had 2 separate cavities within the cord, and if you shunt one, then the other one will expand. This is a patient whose shunt became stuck to the dura and caused its own set of problems. It can become infected, as in this patient, there's a small abscess right here at the tip of the shunt. And you can develop a low spinal fluid pressure state and neurologic deficit. So that said, syrinx shunting should be considered as a last resort when all else fails. When it's done, placing the shunt into the subarachnoid space anterior to the dentate ligament through as small an area of bony removal as possible so that you do not destabilize the spine per se in doing it. If you do a full laminectomy in some areas of the spine, this necessitates stabilization. I've already mentioned that placing it into the anterior subarachnoid space is most favorable. And in the interest of time, I will just show you our own experience from some years ago. Complications can occur with any type of shunt, whether it be into the peritoneal cavity, into the chest, into the subarachnoid space, wherever. And recurrent scar, shunt failure, and spine deformity can all recur as long-term complications. We performed many repeat operations, 99 procedures in 64 patients that we had treated at that time. By any different approach, we tried a number of other things, including a laminectomy with a dural graft to bypass an obstruction, but that, as you'll see in a moment, didn't work all that well either, although you would think it would work well. And so while the majority of patients had only one procedure, we had a not inconsiderable number of patients who had multiple procedures over a period of time. The best results, I don't know whether you can see this, but our best results were really in patients who had an arachnoid cyst, in other words, a very focal obstruction of the subarachnoid space. Patients who had trauma as the cause of their syringomyelia were the ones who were most likely to require revision, post-inflammatory ones as well. So the outcome, many patients were stabilized, many required reoperation, and some improved. And this is just to show you that over a period of time, many patients required extensive laminectomy, patients who had a trauma over several levels to accomplish what we set out to do. So in conclusion, spinal syringomyelia or primary spinal syringomyelia may complicate spinal cord injury, meningitis, or subarachnoid hemorrhage. And it's important to establish the extent and the level of the subarachnoid block. Patients may face multiple procedures to stabilize the condition because of the complications that I've listed. And shunting is reserved when there is no alternative but it is not ideal. But at the moment, it is the best that we can do for some of these patients. And with an extensive laminectomy, stabilizing the spine is important, particularly if the underlying process has been a spine injury, so the patient may already have some instability. Thank you very much.